All righty, folks. Welcome to another episode of the Serdentity podcast. I'm your host, Elizabeth Dewar Anthony, and my guest today is the amazing, awesome Dr. Brian Hockel, who is a general dentist who does orthodontics, but he has also experienced life-changing jaw surgery that opened his airway. So we have a lot to yak about. So let's get to yakking. Hi,
Sounds
Dr.
good.
Hockel. How are
Hi,
you?
hi. Thanks for having me. I'm doing great. Yep, doing great. Glad to be here with you.
You know, so you get what I'm trying to get across to my fellow dental professionals. Dental trauma, there's still lots and lots of people who are afraid of the dentist. You go on dentalfearcentral.org and you can see the stories of these people suffering in the dental chair. And what I find interesting is there's probably a same story in some Facebook group. Oh, I have to rant about this patient. And it's two sides, two completely different perceptions of the same situation. And I understood a long time ago that there was a post-traumatic stress reaction, but it wasn't until I became an orofacial myofunctional therapist that I realized, oh, it's the airway. So Serdentity is the name of my philosophy. It was the name of my book. It's the name of my course. And my ultimate goal is to educate my fellow professionals so that they can have some serenity while they're doing their dentistry. It's win-win. We bring down these people's stress response and everybody has a better experience. So what do you think?
I think it's a great concept. I mean, you're putting together some ideas here that no one really has talked about before. I mean, we talk about the airway, we talk about how important it is and how if it's not working the way it should, then the gag reflex will be increased. We'll be very protective of the back of our mouth.
Mm-hmm.
And then over in the other corner, we know that there are patients who fear dentistry. And it's a really important thing to do to put the two together because now there might be a path forward for some of these patients. It's hard to undo the PTSD type memories that are there
Mm-hmm.
and all of a sudden change that. But on
Yeah.
the other hand, if you can understand more about where the fears are coming from, and more importantly, do something to try to improve them, then that's a path forward for a lot of people that might not have otherwise had it, except maybe with nitrous oxide.
Right. Nitrous oxide, not well, nitric oxide also helps, but it's not nitrous oxide.
Yeah, yeah.
So, the message I'm trying to get across is, when a person is in a fight or flight, they're in fight or flight. They're acting from their primitive brain. And when they're walking into the office, there's things that a professional can look for as the patient is coming in. Wow, do they have a flat upper lip? Do they have forward head posture? Are they hunched over? Are they sitting like this in the waiting room? These are all indications that this person has an airway issue and they may be in a fight or flight state. And
Yeah.
what happens is, um, you know, somebody has a bad reaction, a bad interaction with this person, and then they get labeled. Mr. Jones is a jerk. So then
Mm.
you open the door and there's Mr. Jones, the jerk.
Yeah. Or
And
a baby. He's such a
he has
baby.
a baby or a wuss
Yeah.
or whatever, yeah. And my whole message is you can be proactive when these patients are on your schedule instead of getting mad and feeling sorry for yourself that you have to work with this person. Take a step back and let me show you some things that you can look for, because so much I think it becomes a power struggle because the patient's coming in defensive and they don't want anything done, so they're going to argue. And a patient says, well, I don't want x-rays because Dr. Oz said they're bad, but really they don't want x-rays because of their gag reflex,
Yeah.
but
Yeah.
Dr. Oz gave them the out.
Yeah. And we don't have much more to do except try a few techniques, raise your leg, or just the typical
Mm-hmm.
gagging type um, uh, strategies that we have.
Mm-hmm.
But you're right. I mean, I think one of the things we look at when we do an airway evaluation is there a strong gag reflex?
Mm-hmm.
There is, that tells you right away the body is on red alert. That
Mm-hmm.
space in the back of my mouth is where my airway is. And
Mm-hmm.
without an airway, I'm dead. So you don't go near it. You got to,
Yes.
I'm protecting that with all my life. And if you go in there and do anything and threaten it,
Mm-hmm.
water, air, even just opening the mouth for some people,
Mm-hmm.
you might as well be waterboarding me because it's the
Yes.
same feeling of I'm about to lose my airway. And
Yes.
it's a feeling of desperation that isn't always connected to that aspect of it. The maintenance of the airway is the most important thing. And add to that people whose nasal airways are obstructed.
Right.
Now it's even harder because when I open my mouth, I've got to give you access to my teeth, but you've got to give me the ability to breathe through my mouth or else I stop breathing.
Right.
And just being in there with water and instruments and everything else,
Yeah.
it's getting in the way of my ability to breathe. So
Mm-hmm.
nothing personal, but you're threatening my life.
Right. And so you're the patient's thinking you're you're interrupting my ability to breathe, and we're thinking you're interrupting me when I'm trying to do something really important in your mouth. And I am so, look at all this technology I have, look at how great I am, look at whatever, freaking institutes are hanging on your wall. It doesn't matter. The
Yeah.
brain is going to breathe. And I actually have developed a coaching technique um, to help patients with the gag reflex, and it's helped me get many patients through X-rays by coaching them.
It's
Okay, I want you
great.
to hold your breath and then breathe out. Place the sensor now. Breathe out. Breathe out. Breathe out. Breathe out. Well, you can't gag if you're breathing out. You cannot gag
Mhm.
if you're breathing out.
Hmm.
And that has been pretty successful for me. Um,
So deep inhale, much
mhm.
air as you can, and then
Yep.
just slowly exhale for the
Yep.
amount of time it takes to put an X-ray
Yes.
sensor in
Yep.
and
Yep.
take the X-ray.
Yep. And to
Hmm.
run to the button and run to the, and press the button. Yeah. And it's amazing because then it's like, okay, you can open. It's because as
Yeah,
soon as and they're like, what? It's done? I'm like, yeah, it's done.
yeah. Oh, that's a great strategy.
And I just, I kind of figured that out by accident. Well, for my own, I did all this. I'm like, okay, now how can I do this at home? And I figured it out. I'm like, oh, if I hold my breath, I don't gag. So,
Hmm.
I just took a couple of puzzle pieces
Yeah, put it
and,
together.
and put them together.
That's great. What else? What are the other strategies for the gagging patient?
That is the frequently and a high gag reflex a lot of times will go along with a lot of these other oral movements, like lip tightening, cheek tightening. And what's happening is, so the patient's tongue, right, is low in their mouth. And
Mm,
so the outer facial muscles are compensating for a weak tongue. So that's why you have they, as soon as
yeah,
you touch their mouth, it tightens, or
right.
or they turn this way, or that these tighten all up. And those are the
Buccaneers,
people.
yeah. And
Yeah,
we have to be the ones to say, just relax your
yeah,
lip,
and
relax your lip.
they don't
Nope,
even know
keep
that they're
flexing.
doing it. They don't
No.
even know that they're doing it. And these people are the ones with the V-shaped maxilla with that that I have from orthodontics in the 80s. So
Yeah.
again, once dental professionals become aware of these things, you can be more proactive.
Hmm. I think about right now in myofunctional therapy, there's this, I don't want to say a divide, but there are kind of two sides to the family, the people who come from the speech background and the people who come from the dental hygiene background.
Yes.
And this is a good example of how the whole dental hygiene experience has informed the value of myofunctional therapy for these types of patients.
Well, and you know, and I used to tell my patients too, and it makes me mad that so speech pathologists know how the mouth really works, and here we are checking occlusion, like how do the teeth come together? It doesn't matter. Oh my god, centric occlusion doesn't mean anything if the airway's not open. Oh my God. Am I the
Yeah.
only person that like, can I say that out loud? Oh my God.
Well, it starts out early on. It depends so
Yes.
much on the child's oral posture, on how they
Yep.
use the muscles of the mouth, on what they're fed, the kinds of sensitivities or allergies they may have early on, and then it just develops from there. And a
Mm-hmm.
lot of times it's very young kids that are very protective of their airway too.
Absolutely. And they have the kids now, they have tiny little chins and puffy cheeks because they're mouth breathing.
Right, right.
And
So
you
yeah,
can, yeah, and you can bring your kid to this dental pediatric office. It's like Disneyland. It's really fun, but when they get in the chair, they're still going to be afraid.
right. Yeah, yeah. Well, I was often obstructed as a kid because I had allergies to cats, dogs, pollen, dust.
Mm-hmm.
And I carried a handkerchief around with me everywhere I went as a kid. And most pictures of me when I was younger, and probably even as an adult, showed my lips apart because I was so
Mm-hmm.
often mouth breathing. And it's kind of embarrassing to go back and look at those pictures now.
Right. Yeah.
But I remember, I mean, in the dental chair, there had to be an ability to breathe. And my dad was my dentist.
Mm-hmm.
And he's retired now, but he must have just been very good at giving me the chance to breathe and
Mm-hmm.
sensing when I wasn't. He would say things like, try to breathe through your nose. You're fogging up my mirror. And I did my best, but it gave me a sympathy for my patients who were like that too. And I would
Mm-hmm.
say, if you're like me, you may not be able to breathe through your nose, but if you can, try to breathe through your nose.
Mm-hmm.
So I don't know, probably it'd be a good preparation for just being a good dental patient to go through breathing retraining and
Mm-hmm.
myofunctional therapy to help to change all those factors for the better.
Mm-hmm. I listen, I put my ear to the patient's nose. I'm like, okay, can you breathe? And I'm like, okay, I hear air. You are able to breathe with your nose. And
Mm,
sometimes they don't think that they can, but they can. So it's just
right.
more coaching. And
They're so used to large volumes of air that when
yes.
they switch to their nose, they think they're going to get the same volume of air through their nose, and
Mm-hmm.
they don't. For number one, they don't need that large volume of air, and number two,
Exactly.
because they've been breathing through the mouth, the nose tissues swell up and
Mm-hmm.
now occlude the nasal airway because
Mm-hmm.
of the disuse. So they have
Mm-hmm.
to just make the determination, okay, I'm going to breathe less air and be patient with it until the nose opens a little bit. I'll get a little more after that, but even then, I'm going to have less than I did through the mouth and just stick with it. Uh,
Mm-hmm.
it's probably something that dental assistants could be trained to help a patient do even before they have a procedure. If they know this is a patient who's prone to have that kind of problem, okay,
Mm-hmm.
let's talk a little bit about how you're breathing. And how do
Mm-hmm.
you feel with your nose today? Does your nose feel like it's
Mm-hmm.
obstructed? Maybe even teach them some nose clearing techniques, the ones that Patrick.
Right. Oh my God. The Patrick McEwen
Yeah,
nose clearing technique, that's so easy.
yeah,
And
yeah.
it would take like 3 minutes.
I mean, most of the time, every dentist runs right on time, and there's no time for the patient to sit in the chair. So this
Right.
might not be possible in most offices, but in those few offices where the patient does have to sit for a few minutes because the doctor isn't really ready, then
Mm-hmm.
yeah, it could be a good use of time.
That's amazing. That yeah, like seat the patient, and while instead of like watching Fox News, you can do this nasal clearing technique, and have a little thing of clear nasal spray.
Yeah, yeah, yeah. And for the really hardcore people, you could even have nasal rinses and have them do a
Mm-hmm.
nasal rinse before they start. Because even throughout the day, the nose can congest up like that.
Yes, that's amazing. That is
And
amazing. And how about, so the patient comes in, you sit him in the chair, and you do your couple of sprays of the clear nasal spray. They do the nose clearing exercise. Then you give them a mute nasal dilator.
yeah,
And
oh, that's a great idea. Yeah.
how expensive is that? And in order to avoid, you know, a whole lot of, oh my gosh, you're so smart.
Right, right. It might even
We,
be good to have a video that goes into a little more detail. Well,
yeah,
video, just a trained assistant can do it too. Uh,
yeah.
about the importance of nose breathing, not just for a positive dental experience, but just for
Mm-hmm.
your overall health.
Mm-hmm.
Yeah, have the oxygen advantage. Patrick McCune's book there in the
Right,
operatory.
right. Yes,
Yeah,
that, well,
there's so
yeah,
many
then it should,
possibilities here for dentistry itself, even if they're not into treating airway issues
right.
or aware of how to diagnose it. Yeah, I mean, hygienists really should be looking for scalloped tongue, large tonsils, the receded chin, the mouth
Mm-hmm,
breathing, tongue tie. There are a lot of these things that they can detect just at a glance and know, okay, there's some red flags here about the
mm-hmm,
airway.
mm-hmm,
And then maybe schedule another time with someone in the office to just talk about nasal breathing, nasal clearing, the
mm-hmm, mm-hmm,
importance of it, and exercises they can do at home, and
mm-hmm.
let them try. Uh, People aren't having this conversation, but I think it's an important one.
That's that's the first time. Thank you for suggesting that. Okay, so here's the thing. We're gonna name this after ourselves. All right, we are gonna be so freaking famous. Um, and because pretty soon it's going to be like standard operating procedure in every dental office, and we're going to be famous. But anyway, but that's the first time I thought about actually having the patient clear their nose in the office prior to a procedure. That, I'm sure, would create a much better experience, even if you're not. Here's the thing: we're working in the airway whether we think we are or not. And there's a lot of dentists that market themselves as airway dentists, and they're, it's like, what do you,
I think what that means is they take an X-ray of the airway and they go, "There's the airway." So I
yeah.
am a dentist. And
Right,
it's kind of funny. The technology is out there,
yeah,
or they got a laser, and the laser company says you can release tongue ties with this, and that's going to help the airway. So now you're an airway dentist.
right.
It's almost following on the technology rather than the technology following on
Oh,
the right airway
exactly.
philosophy.
Well, and these laser manufacturing companies should be ashamed of themselves for promoting these courses as, you know, if you buy a laser, we'll teach you this or we'll teach you that. That,
It's their job to sell the lasers. We're the professionals. We're the ones that are
right,
supposed
this is
to
true.
know the difference, but sometimes we're suckers, I guess.
Yeah. I was just reading about a dental practice where the doctor went to a course and they wanted to do platelet rich fibrin
Mhm.
for their patients for bone grafting. So they're like, well, who's going to take the blood? And then, can a hygienist draw blood? I don't, not in New York. We can't do crap here in New York. They're even not letting us do dental hygiene as
Mm.
dental hygienists do myofunctional therapy. Um, there was a
Mm.
practice act, and they
You
said
can't,
that it's not in our standard of, it's not in our practice act, so you can't do it.
it's not in your scope of practice.
Scope of practice,
So
right?
you can do it, but you can't use the RDH after your
Right,
name, right? Yeah.
right. Well, I guess, but people were getting, like, hygienists were getting letters from the state, like, we caught you, we see this pamphlet you gave over there to Dr. Smith, and it says blah blah blah, and so these poor hygienists are just like, what did I do? And you know what? We're a bunch of good girls. Okay. We're all a bunch of good girl, rule following people pleasers. So this sort of thing is very frightening when you get
Yeah.
something with an official head, letterhead on there.
Yeah. Well, we'll find out if it's in your scope of practice to help a patient learn nasal clearing. I don't know. Maybe that's against the law too.
Right. Well, it's really interesting. So yeah, there's a pretty big brouhaha going on here in New York because the Dental Hygienists Association has been after the dental board for a long time for other things.
Mm.
And so they're like, look, we don't want to press our luck. They're finally starting to come around to, dental hygienists as, something other than a tooth kill, a
Tooth
tooth.
scraper.
Yeah.
Mm.
So, it's, yeah, it's just really interesting.
Mm.
But
Well, those are all good things for the initial visit in the office, ways of helping people who might otherwise gag or have a negative experience.
mm-hmm,
And of course, just helping people who don't breathe well to learn how to breathe. But it's
mm-hmm,
kind of the gateway to the discussion of what's happening with their sleep. Because if there are problems with their daytime breathing, there are going to be problems with the nighttime breathing.
Right.
So, I mean, that's the next level to go to, is to ask the questions. Do you get to sleep well, stay asleep well, and wake up
Hmm.
feeling rested? And has anyone said you snore? I think just asking those two
Yep.
things can really open up the discussion. Oh, well, maybe Dr. So and so might recommend that you talk to your doctor about having a sleep study. Even,
Hmm.
if you don't, uh, you can't offer them yourselves always, but in our state, we're able to dispense the sleep study, uh,
Hmm.
the home sleep test, and the interpretation and the diagnosis comes from a board certified sleep doctor. So we're not doing that, but it becomes a very easy way for patients to learn, oh, there is something going on. And
Hmm.
home sleep test is very limited. It's less information, less hassle, less money, but
Hmm.
also less useful, and
Hmm.
a lot of less, as
Hmm.
Dr. Gersten says. But an overnight study in a lab is a lot more. It's more time, more hassle, more money,
Hmm.
but it's also a lot more information and can lead
Hmm.
to the right diagnosis. So whatever it takes to just kind of be the gateway drug to get them in the
Hmm.
system, to
Hmm.
realize there could be a health issue here that is affecting how long you're going to live, your quality of life, and oh yeah, maybe even your gum health and your dental health might
Right.
be related to that if you're in a constant state of sympathetic nervous system
Right. Because you're the
response. Yeah.
bacteria, yeah. The bacteria, the mouth between the fight or flight and the dry mouth from mouth breathing, the bacteria are in heaven. They are
Yeah. Yeah.
living, yeah, the life of Riley, and and then these bacteria get in the bloodstream, and you know, the bacteria going into the bloodstream is still, it's a relatively new thing to talk to patients about. I mean, we know, but we've got to start because it's,
And the biofilm, it's been all about plaque, but
yeah,
we need to increase the awareness of biofilm
yeah,
and what biofilm is. It's everywhere in our water lines, in our sink, and stuff that we don't rinse out frequently. The dog's water bowl,
right.
biofilm is everywhere, and what's in it is bacteria. And you
Mm-hmm.
may not know, unless you do a saliva test, a bacterial test, whether one of the 11 pathogens is there that's causing the problems in the mouth. But I
Mm-hmm.
think we have the opportunity to go to much higher levels of health looking at it from that standpoint. And
Mm-hmm.
how we breathe affects that a lot. Like you said, the gums
Exactly.
drying out. Yeah.
Mm-hmm. So, well, the ADA, I talked about this at my talk. The ADA just had that big meeting where, you know, a bunch of people were speaking about this stuff that we're talking
Mhm.
about, and
Yeah.
they're on board. So it's really exciting. You know, and that the dental profession is going to hopefully really step up to be part of primary care.
I hope so. Yeah. I haven't heard what came out of that most recent meeting, but there's a lot of opportunity there. That's for sure.
Well, they had the meeting. I mean, that's the first thing. They had the meeting. So
Yeah, and hopefully they'll have some influence, because even though meetings happen and influential bigwig people in the organization talk about it, how it filters down to daily use, I don't know. I don't know. You need to write an article maybe for the ADA News that talks about, hey, airway has been out there. So here's one just tiny step you can make that might even make your life easier with those gagging patients.
that oh yeah, the nose clearing with the nasal tie layer.
Yeah. So and then going to the next step, it is first that the breathing, and then looking at sleep, and
Mm-hmm.
then looking at what's happening with the structural and the functional side, getting a
Mm-hmm.
myofunctional therapist involved when necessary,
Mm-hmm.
and looking at the structure from the standpoint of airway health. And nowadays it seems like it's all about side to side expansion, however you do
Right.
it. And the
Yeah.
argument seems to be, oh, you're only tipping teeth. Oh, you're opening the suture. Oh, you're going too slow when you open the suture. You're going too fast. But it's all about transverse expansion.
Mm-hmm.
And we know that really most of the deficit in the growth of our face comes from the maxilla being down and back, which
Mm-hmm.
holds the mandible down and back. And if they're down and back equally, then you get a face that looks pretty typical for our world. And you don't
Mm-hmm.
think of it as somebody who's really weak chin.
Mm-hmm.
But the fact that both jaws are down and back is going to lead to a risk of the airway being compromised,
Mm-hmm.
and trying to do something about that as well as the side to side. The transverse is
Mm-hmm.
important. Got to have enough room for the tongue in that dimension, but you also
Mhm.
have to have enough room in the front to back dimension. And that
Right.
opens up ways of doing orthodontics that are very different from what's being practiced in 99.99% of offices that do orthodontics.
Oh, well, I'm classic extraction retraction, and I have a CPAP.
Yep, yep. Well, so I mean, if CPAP works well, great. That's a good option for someone. But if someone doesn't want to use the CPAP, then one option might be reopening those extraction spaces. And then the
Hmm.
number of doctors who have experience in reopening spaces and doing it in a way so that it's going to be predictably good for the appearance of the face, good
Hmm.
for, the ability to replace that tooth, and know when that's appropriate, because
Hmm.
sometimes it's really not.
Hmm.
But reopening extraction space is an option, or even somebody who has not had extractions like you. Sometimes it's worth opening extra space, putting in
Hmm.
an additional premolar to
Hmm.
increase the volume of space the tongue has. The whole reason for all of this is for the airway to be able to function better.
Hmm.
So if somebody's to say, yeah, but your root inclination isn't ideal, or the way your cusps interdigitate, that's not ideal. If you look at the kind of hierarchy of values that are there, the airway really takes precedence over some other things
Right.
that we've given. It's not that we've given precedence, just to us, that's been the whole world, is how the
Hmm.
teeth fit together, making teeth fit on jaws that don't fit, as Bill Hang says.
Yes, making, yeah, and yeah, making teeth fit on jaws that don't fit. And the airway just laughs. Okay, your brain laughs when we do this stuff because it's like, okay, that's great, but here I'm going to move it. I'm going to move it. And that's why I love these emerging thought, thought processes in orthodontics. It's so, but you got to get to these kids really little.
Well, one thing that's emerging, like it or not, is the public's awareness that what they do with the tongue and all the muscles around the jaws and teeth really does make a difference. That
Hmm.
it can have an effect on how you look. And we live in a world where people tend to want to pay attention to how they look, almost to an extreme,
Yes,
pathologic extreme, you
absolutely.
think sometimes. But as a result, the hashtag mewing has been used a
Yes. Oh,
billion
all the
times.
kids, they
And
all know about it.
they know, and I'll ask the kids. So, do you know what mewing is? Oh yeah, I know what that is. And the mom will go, "What? How do you know that? What's that? Tell me about that." And so the kids know before the parents do. But so also do the 20 and 30-year-old males, especially. It seems like it's not
Hmm.
just them, but that are obsessed with their appearance. And look at me before I did mewing. Oops,
Right,
sorry.
right. Yep.
Here's me before I did mewing. Here's me after I did mewing. Look at how my jaw came forward. And whether it's working in the way they think it's working or not almost
Hmm.
doesn't matter, because they've made the connection that what they do with the muscles of the mouth matters. And it matters to how they look, it matters to how their teeth are arranged.
Hmm.
And that's going to take like a tidal wave that's going to take the orthodontic profession really by storm,
Hmm.
because that's a much more powerful opinion than an orthodontist saying, well, there's no studies saying myofunctional therapy really makes a difference. So all mewing is DIY myofunctional therapy, and
Hmm.
without a guide, and it's better than nothing, but
Yeah. Right.
better to have somebody with a guide. But my
Right.
point is that that's going to be out there, and that's going to be in the way of thinking about how we use the muscles of the mouth, so much so that orthodontists who say, oh, none of that matters, are
Oh,
going to decrease their own credibility.
exactly. And another point that I make, we're the professional, we're always about this empirical evidence. Where's the studies? Patients don't even care about empirical evidence. Patients care about what they see on social media. They care about what happened to their friend or their relative. And I can sit there, well, there are studies say blah blah blah, blah, and they're like, yeah, we're always talking about all this research and science, evidence based. Well, for one thing, where did that evidence come from? I'm sure you know about the sugar lobby paid Harvard to release that study that said it was fat that makes you fat, and that started the
Yeah.
entire low fat craze.
There's the bias of who's paying for the research.
Yes.
There's also just the research ability of the thing you're looking at. Because I
Mm-hmm.
don't we're ever going to be able to have methods to determine where people's tongues are at different times of their day and night. And that might be one of the things we would need in order to correlate that with, for
Hmm.
example, intermolar width or growth
Right.
through
Wow.
pattern in
Yeah.
general. So some things are just very difficult to research. But then the third thing is research with double-blind controlled study isn't everything. We've forgotten how to use logic. We should be
Right.
able to
Right.
use
Oh,
logic,
logic.
right? So I have so much fun with 5 and 6 year olds and 7 year olds by saying, so let me ask you, Susie, if I were to bring your front teeth and pull them backward in your mouth, do you think your tongue would have more room or less room? And in a heartbeat, they say, oh, less room. Really? Did you go to orthodontic school? How did you learn that? On second thought, they don't teach that in orthodontic school. The tongue doesn't seem to matter. So, but you know what? You now know more than most orthodontists about something that's almost more important than what they're doing. And
Hmm.
it's logic. It's not that you need a study for that. And
Hmm.
it's borne out in so many of the things we do, because if we bring the front teeth forward and reverse that kind of a process, then the tongue, the airway will have more room in a lot of cases. It'll feel better because it's better for the joints, and you can breathe better because now there's more room sometimes for the jaw to come forward a little bit. You can't count on that, but
Hmm.
always for the tongue to come forward. And the hard part is we just don't know who that's going to help and who it's not going to help.
Yeah.
But since we don't know, that's really the argument in favor of just using logic to say, don't ever retract. Don't pull teeth backward in the mouth,
Right.
because you're risking giving the tongue less room, which is a risk to the airway. And it doesn't take very much. For some people, it's less than a millimeter can make a big
Hmm.
difference. That sounds extreme, but it is true. Once you get into this rabbit hole and this world of patients who are suffering from problems like this,
Hmm.
it that's how it is. It's very small tolerance.
I say when I tell my patients, fortunately, air doesn't require a lot of room. So if we can make even a little bit more room for your tongue to be up and forward, that's going to help you.
Yeah, yeah. Make the
So
room, but then train it.
yeah, yes, get it up forward. And Dr. Zaghi just was talking about, we got to stop calling it a posterior tongue tie. And it's really because it's not the posterior, it's the middle. It's the middle of the tongue that we're really talking about. But at least we're talking about something. So.
Right, right. I've kind of given up on trying to be precise in my nomenclature. I just want to work with myofunctional therapists who know what they're doing and have them kind of direct that whole process of any frenum release. I'm
Hmm.
fine with that. My own personal myofunctional therapist is Joy Moeller, and she's
Oh,
helped tremendously. Yeah,
well,
she's
she's the
one of the best.
OG. I mean, she's the queen.
Yeah, I'm most of the way through the Audible of her book, Is Your Tongue Killing Me?
Uh-huh.
And it's a good book. It's a collection of some different views of what's going on, but she did a good service with that. And
Hmm.
so whoever someone sees, they need to have a myofunctional therapist on board. And that without that, the orthodontics create the room for the tongue isn't going to be as successful.
Right.
And without that, of course, any frenum release, whether it's whatever part of the tongue it's
Hmm.
releasing, isn't going to be as effective.
Yeah. You know, um, I told myself, even if I never saw a myofunctional patient, it made me a way better dental hygienist. I just I
Yeah.
understood, and I was able to educate my patients. They're like, "Wow, really? Who are you kidding? Wow!" I had on my screensaver, I had that photo of the ancient skull and the modern skull. I'm like, look at that. I mean, which do you think has more room for the tongue in front? Just like you asked those 5-year-olds, and they're like, oh, well, that big one. Yeah, it's
Yeah.
why do they call it common sense? Well, it's like not very common.
Yeah. Well, I think over time we're going to see things changing more, just as word gets out there and more it's talked about. So my big focus really is on helping people understand what retractive orthodontics is, because
Mm-hmm.
they understand that retraction and decreasing the tongue space is not good. But
Mm-hmm.
what they don't always understand is that very common ways of treating orthodontic bite issues are retractive, even when
Yes.
they don't seem they're retractive. Even when they're
Mm-hmm.
in the office of an airway orthodontist, they still work the same way as they do in the office that isn't an airway
Mm-hmm.
orthodontist. anything that brings the lower jaw forward during treatment
Mm-hmm.
is going to have a retractive effect on the upper jaw. And this could
Wow.
be, yeah, anything that brings the lower jaw forward and attaches it to the upper jaw. The sleep apnea appliances are a good example. They bring
Mm-hmm.
the jaw forward, they attach it, and what do? We have the patient sign a paper that says your bite could change
Mm-hmm.
because sometimes it does. They say,
Yes.
I've been sleeping great, but now only my front teeth touch and my back teeth don't meet anymore.
Right. Yes.
Oh, well, that's
Oops.
because there was a mysterious alien force pulling back on your upper jaw. And this happens with, how about the low-tech, old-school Herbst appliance
Oh, those things were
attached to
so
teeth?
awful.
Yeah, well, they work to get the molars class 1 because we were taught by Larry Andrews' 6 keys of occlusion, we have to get the molars to be class 1. And we were taught that we can't leave overjet. We have to correct the overjet. So when you first put the Herbst appliance in, the lower jaw comes forward, and it might actually help someone sleep better because it's like a sleep appliance
Mm-hmm.
attached to the teeth now. But over time, Newton's third law, there's an equal and opposite reaction pulling
Mm-hmm.
backward on the upper jaw, and it's going to be retractive. So there's the Herbst, there's the Mara, the Bionator, the Twin Block, all the
Mm-hmm.
functional appliances that aren't really in use that much anymore. But now, you know what? The latest two that you'll see a lot of, even in airway circles, are Invisalign MA.
Mm-hmm.
Mandibular advancement is what it stands for. There are
Mm-hmm.
little protrusions off the side of the Invisalign aligners that
Mm-hmm.
make it so the kid has to hold their lower jaw forward in order to close. So it has a retractive effect on the upper jaw. And hopefully, I mean, the intention is for the lower jaw to grow further forward. And those are great intentions. I
But that's
applaud the
not, yeah,
person,
that's not the right thing.
but we don't know. We don't know. We know that it's going to have a retractive force on the upper. And if it has a retractive force, then there can be some retractive movement. And
Mm-hmm.
even if it's a fair amount of lower coming forward and the upper coming back also, they might say, oh, but it's such a small amount. It's not clinically significant. Yeah, well, how do you know that? The burden's really on you to prove that. So that's one, Invisalign MA. The other one that's very retractive is the any kind of preformed appliance. Name
Mm-hmm.
your brand. There are a lot of preformed
Yes,
appliances
there
out there.
are.
Just bite into this, and this is going to be your myofunctional orthodontics. And
Yes.
but if there's overjet, a
Mm-hmm.
horizontal distance from the upper and lower front teeth, and the
Mm-hmm.
lower jaw has to come forward to come into that preformed appliance,
Yes.
then it's going to have the same retractive effect on the upper. And what we have to remember is not only that retraction is bad, but those upper teeth are already too far back. They need to
Mm-hmm.
be further forward. So we're not only not bringing them forward, but we're bringing them backward. So Invisalign MA and the
And
preformed appliances are two that I think people may not be aware of because they're in common use in orthodontic offices.
mm-hmm. Well, and there's more, and myofunctional therapists are recommending, and can dispense some of these products. So that's good to know.
Yeah, if there's no overjet, if the front teeth are edge to edge, then I can't imagine that it's going to have any retractive effect at all. And if it's being used for a limited amount of time to help train on nose breathing,
Mm-hmm.
then I can't really object to it. It may not be the way I would choose to do it, but I can't
Mm-hmm.
object to it in that case. But when there's overjet, or even just a normal bite, never
Mm-hmm.
mind excessive overjet, just a
Mm-hmm.
normal bite, you're going to have to open, come forward, and close into the plastic, and that can have a retractive effect. So
Wow.
it's not bringing the front teeth forward, it's retracting the upper front teeth potentially, depending on how much it's worn and how well it's worn, and it's wasting time and money. I feel like that's a period of time in the child's life, time, money, and cooperation. Kids will
Mm-hmm.
burn out because that takes a lot of cooperation to wear a preformed appliance.
Mm-hmm.
And when you've chewed up that time in their cooperation world, there may
Mm-hmm.
there may not be an opportunity for something else later on that's more effective.
Mm.
So the objections we get are,
Excellent.
well, it's better than nothing. No. In my opinion, some retraction or risk of retraction is not better than nothing. Find something else. It's not better than
Mm-hmm.
nothing. Oh, but we can use this for the masses. We can have people sign up online for a big
Mm-hmm.
program, and we can send
Mm-hmm.
out lots of devices to people who would otherwise have no hope of having good airway orthodontic care.
Mm-hmm.
Really? Well, this isn't, in my book, airway orthodontic care, if it's risking the potential for retraction.
Hmm,
So, and then add to that the very common class two elastics. Anything
right.
that the rubber bands from the, you probably had that after your extractions,
It,
from the top in the front to the bottom
yep,
in the
yep,
back.
yep.
Yeah. Nobody uses the headgear anymore, but
Thank
they're
God.
they're basically coming up with ways to do what the headgear did without
Hmm.
the headgear.
Yeah. Well, the Sandra Khan has uh that
The
face
bow.
that face gear. That's different, right? Is
Yeah,
that different?
well, it's aiming for forward growth of the maxilla.
Mm-hmm.
And but the problem is it often has a very downward force. And what I've seen in
Mm-hmm.
my experience is that it can tend to lengthen the maxilla. Yeah, maybe it's pulling it forward some, but it's probably also pulling it down, which
Mm-hmm.
is very counterproductive.
Right.
So all of these things that retract are setting up the patient to be the patient in the dental chair that's fearful of anything in their mouth because
Yes.
now their tongue has less room. So to bring
Yes.
it full circle, that's kind of the
Mhm.
connection we're trying to make here is anything that's being done retractive is creating patients that are potentially the fear patients because they've got a very fragile airway.
That is amazing. Wow, you are so smart. And this talk has been great, and you make me feel like I'm smart because I know what you're talking about, and
Good.
that's really really cool.
Well, you've
Um,
been at this a long time. I think you understand it pretty well.
well, and I would, but it makes me sad for the amount of time that I didn't know. You know, I was a hygienist for 36 years, and yeah.
All we can do is go forward.
That's right. Do you want to show any slides or we've been on here
Oh,
for 45 minutes?
well, okay, yeah. Well, before we go off, let me brag about what I did about my own small airway. This was me one day before and 3 days after I saw an oral surgeon in St. Louis named Reza Movahed, who
Uh-huh.
brought both my upper jaw and my lower jaw forward and made a very big difference in terms of where the jaws were.
Oh my
But I
God.
didn't really care how I looked, especially not how I look in an x-ray.
Wow.
That's a custom plate holding my upper jaw in its new position on the maxilla, and then what they call the Z plate and the L plate on the lower holding the mandible forward,
Oh my God.
where yeah, it's amazing what a good surgeon can do with something like this. But I had to have myofunctional therapy, have the tongue tie release. And if you compare where I was
Yes.
to the ideal before and
Mm-hmm.
after, it's not exactly where it should be. And I've got 61 years of forward head posture. And so
Yes.
some things are just going to be really hard to change. But I think it made enough of a difference for me that it was well worthwhile. So that was one day before, 3 weeks after, and then a year later,
Wow.
basically. So I want to fast forward. I had to retake my professional picture finally after 9 years. But this is the picture I
Wow.
wanted to show you because
Yes. Look at
that's
that.
that's what an X-ray of a dental fear patient looks like on the left side. And
Yes. Thank you.
yeah, they measure the smallest section of it, and for me, it came to 22 square millimeters, which is really small. And it was seeing that X-ray that made me make the decision. I don't care what this is going to do to us scheduling wise, financially, family wise, practice wise. I'm going to take a big hit in probably every area of my life. But you know what? Uh, I'm going to, I may not have the life to live if I have to deal with
Mm-hmm.
that airway for long term. And that's the
Mm-hmm.
kind of airway that someone has when they have a stroke, a heart attack,
Mm-hmm.
cardiovascular disease, diabetes, so many different health issues. So anyway, fast forward, and it's now 12 times bigger than it started out at 266 square millimeters.
That's
So in my
amazing.
yeah, in my case, it was worth it doing that. There were some
Mm-hmm.
downsides. It's definitely a cost and a hassle. Take
Mm-hmm.
time off, change your diet. Have to go through orthodontics, wear braces, deal with
Mm-hmm.
recession of gums. I've got more spaces between my teeth now.
Mm-hmm.
I have to use a little traveler. What do you call it?
So the
Proxibus.
Tepi is the
Yeah.
best interproximal brush.
Oh, yeah, I love it. And on my trip right now, I meant to bring a new water pick with me because I've been so dependent on them, but
Mm-hmm.
forgot. So I just use the proxy brush. I've got a
Mm-hmm.
little bit of numbness in some areas that I live with
Mm-hmm.
okay. Change of it, what I, how I eat, definitely different. It's taken me a year to get back to where I could get back in my workout routine.
Mm-hmm.
'Cause I lost some momentum, but I have a better smile. I can relate to my patients. and I have a lot more confidence even than my surgeon I've worked with for many years. But the
Mm-hmm.
big things are breathing during sleep is easier, nose breathing is easier, sleeping on my back is possible. I do that every night. I use a pillow that Joy recommended, the neck nest pillow.
Mm-hmm.
I travel with it now. I've got it on my bed when I go anywhere. I
Yeah.
sleep through the night more. That's the greatest feeling, to just wake up and it's time to wake up in the morning.
Right.
No snoring, waking up feeling more rested, better energy during the day. I don't have to tilt my head back. Working on patients, I would have to kind of, well, that's a different thing. That when I was sleeping, I was having to tilt my head back, sleeping on my
Mm-hmm.
side, on my stomach.
Mm-hmm.
Don't have to do that. It's easier to have better neck posture. Not that
Yes.
I do it all the time, but I can now do it without choking off my airway.
Mm-hmm.
This is what I was going to say, is working on patients, I'd have to hold my lower jaw forward a little bit to keep my own tongue out of my airway at the
Yes.
same time as I'm getting in the way of the patient's tongue and
Yes.
airway. But I don't have to do that anymore because it's big enough. So God willing, hopefully I'll be able to live a little bit longer because of it. And I think it looks better, but it's not the reason. So if I'm
Mm-hmm.
comparing the two, was it worth it or not? Definitely, to me, I would say I have no doubt that I would do it again in a heartbeat because of the long-term change. Wearing a CPAP can be just as effective for a lot of people, but
Mm-hmm.
I don't know. There's stuff that can be done in the OR that you don't have to understand all the details of. Kind of like I don't
Mm-hmm.
understand how they do my daughter's heart surgery. All I know
Mm-hmm.
is my airway's bigger, I feel better, I sleep better, and I wouldn't trade that for anything. So
Mm-hmm.
anyway, shout out to Dr. Reza Movahed, who's an amazing surgeon.
That,
So,
thank you so much for sharing that. That how much did it hurt though?
hurt? I
Yeah.
don't remember pain being a problem with it at all. The first couple
Wow.
of days you're on narcotics, and my reaction to narcotics is I sleep. I was kind of
Mm-hmm.
sleeping most of the first week, probably. I think somewhere in the second week I switched over to Tylenol and ibuprofen, and
Mm-hmm.
that was enough to handle it.
Okay.
The pain was really not a big part of the whole experience for me. There's no wiring the jaw shut. You wear rubber bands from the
Mm-hmm.
braces up to bottom. You have to stick with liquids for a few weeks and then softer foods for a while and work your way into harder foods over the next few months. So
Mm-hmm.
the transition with eating,
Mm-hmm.
myofunctional therapy helps, physical
Mm-hmm.
therapy helps. But yeah, people ask about the pain, but
That's like people's biggest concern. How much did it hurt? How much is it gonna hurt?
yeah, no, I closed my eyes, opened my eyes, and it was done. And of
That,
course, I had a bunch of stuff wrapped around my
right,
head,
right, right.
the tubes in my nose to keep my nasal airway clear. And but then I went back to sleep. And within a couple of days, I had to be up walking around and
Right.
getting enough protein and water and all that. So it's like anything else. You get through it. And for me
Mm-hmm.
now, it's in the rearview mirror.
Mm-hmm.
Over a year ago, last Saturday was 1 year to the day since that I had the surgery.
Mm-hmm.
So I don't know, but now I've got the rest of my life to enjoy the benefits of it.
Mm-hmm. Mm-hmm. Well, thank you so much for sharing that. And good on you for following through on that. This has been a one of my longest ever podcasts, and it's been a great conversation. Um, Thank you so much for thinking of me and for coming on. And I want you to and
Well,
taking time out of your vacation to talk to me. My gosh.
it's my pleasure, Beth. I'm glad we could do it, and good luck to everybody listening to it. And if anybody ever has questions, feel free to reach out to me. Um, my email is just my name with an at between it, brian@hockel.com. brian@hockel.com. So always glad to help out anyone I can.
That is so great. I'll tag you on Facebook as well.
Sounds good. Thanks
Uh,
again.
all
Have a
right.
good one. Take care.
Okay.
Okay, bye-bye.
Bye.